We are back with another NRG Oncology Podcast, and today we're returning to another important NRG Oncology trial presented this year at the 2024 American Society of Clinical Oncology annual meeting. I'm joined today by my co-host, Dr. Stephen Chun and Dr. Anuja Jhingran to talk about the long-awaited results of RTOG GOG 0724 for cervical cancer.
Dr. Jhingran is the principal investigator of RTOG 0724. She's also a professor of radiation oncology specializing in gynecologic cancers at MD Anderson, and also serves as the executive director of radiation oncology for the MD Anderson Cancer Network. Dr. Jhingran, I want to give people a sense of how long you've waited to get this trial across the finish line. In the old RTOG nomenclature, 0724 would have meant that this trial first got off the ground in 2007. As a throwback to 2007, about 20 years ago, I want to put this in perspective. Steve Jobs introduced the first iPhone. Britney Spears shaved her head. Netflix came out with their first video, and Beyonce's Irreplaceable was the song of the year. So other than RTOG protocols, what was going on in your life in 2007?
So in 2007, my youngest was 7 years old. So I was probably watching soccer games for all three of my kids, and being a young investigator and excited about getting a cooperative good trial going. So I think that was what was going on in 2007.
That is some amazing context. Before we delve into the design and results of 0727, I first wanted to cover some terminology, especially for those in the audience who might not be as familiar with our oncology jargon. The primary question being asked in 0724 is one that is about two drugs known as carboplatin and paclitaxel. Can you tell us exactly what carboplatin and paclitaxel are, and a little on their history as chemotherapy, both in the general sense and then specifically for gynecologic cancers?
Yeah, so carboplatin and paclitaxel are actually the two most common chemotherapy agents that are used for gynecological cancers. So it's the primary chemotherapy agents for ovarian cancer, for endometrial cancer, as well as cervical cancer. There are two different agents with two different side effects. Carboplatin side effect is really a little bit of nausea. Paclitaxel actually has a bigger side effect. It actually will cause hair loss. It causes neuropathy. But both of these agents together really are the key agents that are used to treat almost every gynecological cancers there are. They're the first line of chemotherapy for all three of these types of cancers.
And so also as background, could you go over the chemoradiation backbone after hysterectomy for high-risk cervical cancer? I don't treat gynecologic cancers anymore, but I still remember in residency having drilled into my mind, the Peters study, the 3Ps, as indications for chemoradiation after hysterectomy being the first P, positive margin, the second P, positive lymph nodes, and the third P, parametrial involvement. So if you could just tell us a little on the history of that chemoradiation backbone in this setting.
So, and this is a great question. I mean, this is actually a great question because the study is the end results of the Peters study. So the Peters study actually looked at patients with very early stage cervical cancer who had high risk factors, which are the 3Ps that you mentioned: positive margins, positive perimetrium, and positive nodes. And what they found in that study, so they looked at a standard group that had just radiation therapy alone, and then they had another group that got chemotherapy plus radiation. And the patients who had these high risk factors, the 3Ps, did better with chemotherapy and radiation versus radiation therapy alone. But when they reanalyzed this, they found that the patients who benefited most from the chemotherapy were only the 2Ps, positive perimetrium and positive nodes. And so that is how the study came out, was to take out the two positive high risk factors, positive nodes and positive perimetrium, and see if we could make it even better, because these patients even though did well with chemoradiation, still had a high recurrence rate, both locally and distantly.
So I think that is really a perfect segue to talk about the study at hand. And with all this in mind, can you tell us about the rationale and design of RTOG 0724?
We found that chemotherapy did not add anything additional for patients with positive margins, and those patients probably actually just needed higher doses, right? But the positive node and positive perimetrium did benefit from the addition of chemotherapy. But like I said, we still had high recurrence rate, both locally and distally. So we're like, how can we improve? The big thing with Peter study, which is a little bit different than any other studies that were done, was that the chemotherapy was done a little bit different. In the Peter study, the chemotherapy consisted of 2 drugs. And those 2 drugs were given the first week, the 4th week, and then 2 more were given after the radiation was over. So all total was 4 courses of chemotherapy. And in a subgroup analysis, they looked at, does the course of chemotherapy, the number of courses of chemotherapy, make a difference? And they actually found that patients who got 3 or 4 courses did better than the patients who just got 2. And then at the same time that this was all going on, like 2006 and 2007, multiple other studies showed that there may be a benefit to giving chemotherapy after chemoradiation. So the question came up, from the Peter study, is it the chemo with the radiation, or is it the chemo with the radiation plus more chemo that makes a difference?
Kind of just to clarify to, audience members, what's being described here, 0724, that is these high-risk cervical cancer patients after hysterectomy getting the standard arm chemoradiation versus chemoradiation plus 4 cycles of carboplatin and paclitaxel. Is that correct, Dr. Jhingran?
So the whole question was, is the chemo with the radiation enough, or do we need to add more, and will that improve local control and distant metastases, right? So adding chemo afterwards, will that improve your local control and distant metastases? So that was what it was comparing.
Right. And I think, also it was, kind of a companion trial in some ways to the Outback trial. We'll get into that maybe a little later. But
Yep.
without further ado, tell us what the results of 0724 were that were presented at ASCO this year, and how surprising were those results to you? Again, I think the Outback trial, which asked a similar question, but it was the question of high dose carboplatin and paclitaxel after chemoradiation, but very similar results. If you could talk about these results that you just presented.
Yes. So, great question again. So let's talk about the Outback trial. The Outback trial is basically asking the same question that 0724 asked, but in a totally different population. 0724 looked at patients with cervical cancer, early stage, who had a hysterectomy and staging. And if they had high risk factors, they were then put on 0724. The Outback trial looked at cervical cancer patients who had locally advanced disease, so they could not have surgery. So their treatment was chemoradiation. And so what the Outback trial looked at was, is chemoradiation therapy enough, or adding, again, the same thing, carboplatin and Taxol after chemoradiation better? So same question, is there an advantage to adding chemotherapy, adjuvant chemotherapy, or chemotherapy after chemotherapy and radiation better than chemotherapy and radiation together alone? So the big question in both 0724 and Outback was, should we add more chemo after the standard chemoradiation? And the Outback trial in 900 patients with locally advanced cervical cancer showed no advantage in adding adjuvant chemotherapy after chemoradiation. So patients who got chemotherapy and radiation therapy did just as well, if not slightly better, than the patients who got chemotherapy and radiation followed by more chemo. And in fact, adding the more chemo increased toxicity. So the patients did not finish their treatments, and they had definitely more toxicity. 0724, same question, same results. The patients who got chemoradiation did just the same as the patients who got chemoradiation followed by chemo. And again, more toxicity, no difference in progression-free survival or overall survival. So same results. So were we surprised? No. And I think the big advantage is this just adds to that literature and basically, as my last slide says, puts that nail in the coffin of there is no advantage in adding further chemotherapy after chemoradiation in patients with cervical cancer in any stage at all.
Let's say we can get Emmett Brown's DeLorean and go back to 2007. Is there anything that you might tell a younger version of yourself to consider differently in the design of this trial? It is surprising in many ways, the results that we saw, given the high risk still of distant metastases in this patient population. We saw that 37 out of 50 disease failure events were distant metastasis formation. It seems like chemo should help these patients maybe in driving down those rates. Would you maybe have asked for more phase 2 data before proceeding with the phase 3, or what could we consider differently as a field?
Yeah, it's a very interesting question. In 2007, I don't think there was anything different that I could have done. I think the key is I would have liked to have finished this trial sooner, so we would have had these results sooner, right? Taking this long for it to complete was not helpful. I think in 2007, I would have either done a phase 2 study and made a smaller study, or have tried to get more international collaboration and made it, a quicker study. I do now know, but we didn't have that in 2007, right? But that's why what I've learned is we need to do great trials, but we need to do trials that don't take so long to accrue because it takes too long for us to get these results. So that is how we are going further collaborative groups, is we're looking at trials that we can complete within 2 to 4 years instead of 10 years, because by then it's too late and there's so many new drugs. So since 2007, there are so many new drugs, right? And the key is immunotherapy. And we have found that immunotherapy may reduce distant metastases. So now that's probably the next trial that should happen, is looking at immunotherapy and radiation and chemoradiation. But again, we are looking at that, but we don't have the right, we don't know where to add it. Should it be induction? Should it be with radiation, or should it be after? But 2007, I would have looked at myself and said, doing a 14-year trial is not the right answer.
So this is really interesting what you bring up about this move away from high-dose cytotoxic chemotherapy like carboplatin, like paclitaxel. This really seems to be a trend that we're seeing in multiple cancers. As you know, I treat a lot of lung cancer, and I think about how the NCCN guidelines were modified to recommend against high-dose consolidated carboplatin and paclitaxel after chemoradiation for locally advanced lung cancer in favor of immunotherapy. Do you have any insight why high-dose cytotoxic chemotherapy like this might not have worked in spite of all evidence suggesting that it might?
Yes, it's a good question. I don't think we have an insight. We really thought it was going to work, right? I mean, we had all the data that showed it worked, but it didn't. So it's the same thing as in lung cancer now, Dr. Chung. The NCCN guidelines going to say you should not give adjuvant chemotherapy. I do think, I think cervix cancer is definitely an immunological cancer. It is caused by HPV. I do think that's why immunotherapy, especially Pembro or anything that's targeting PD-L1, is going to be the way to go, because it is caused by a virus, right? So we did not know that. I mean, we did know what caused cervical cancer, but we didn't have all that data on immunotherapy in 2007. Now we do. And we do have so many agents that will target, immunologically. And I think that's probably the way to go in cervical cancer for that reason, and probably why cytotoxic drugs didn't work as well after chemoradiation. But why, we don't know. We don't know why it didn't work. We were all surprised. We were surprised Outback was not positive, and we weren't surprised by the time we got 0724 because we already had the Outback trial. But why immunotherapy works is probably because it is caused by a virus.
Yeah, I almost wonder if somehow we've crossed that therapeutic ratio threshold with adding, even more fuel to the fire with chemotherapy and just further suppressing the immune system to the point that, additional chemotherapy was counterproductive. But, who knows? I agree. There's no clear answer.
It's really fascinating to think about these things and to, of course, shed the hindsight 2020 vision on these studies and think about what questions we might ask instead. And of course, that helps us design moving forward. Although we didn't achieve the primary objective of 0724, do you think there's anything we might learn in this trial, particularly among things like stratification factors and quality of life analyses?
It's really an interesting study, right? So patients who had higher dose of radiation than patients who also had brachytherapy actually had a worse prognosis. So this comes back to that whole positive margin. And we definitely think it's these patients probably had a higher disease burden. So, there's a lot of questions that are coming up that we really do need to address as we write this paper. Why do patients who have higher dose and brachytherapy have worse prognosis? And I really think it's the disease burden. And that goes to, do we need to go to higher doses for those, which goes back to that positive margin. I think what we've learned from this is, one, we really need to probably do more phase 2 studies that we can get quicker answers to. Two, as we advance, immunotherapy is going to be the way. We have some positive studies like Keynote right now that shows that adding immunotherapy to chemoradiation benefits definitely a certain group of patients. We've also have some studies that have shown that adding immunotherapy to chemoradiation doesn't benefit, right? So our trials next need to show, how do we add immunotherapy? Is it before chemoradiation or is it after? But there's so many questions that are being raised with the advent of immunotherapy. And I think the advantage of 0724 is that it's finally closed that door. We know adjuvant chemotherapy makes no difference in cervical cancer after chemoradiation, right? So that door is closed. So that's good news. That means we can move on and figure out what does make a difference. And it's probably immunotherapy, but then the question is, where? How do we do it? Is it before? Is it during? Or is it after? Or is it a combination of all? But shorter phase 2 trials that we can get quicker answers as we move in science so quickly nowadays will be a better way of answering those questions.
Well, Dr. Jhingran, I want to thank you again for joining us for the NRG Oncology Podcast. And I really want to congratulate you for getting RTOG GOG 0724 across the finish line. I know it's been a long time in the waiting for this. The NRG Oncology Group is supported by funding from the National Institutes of Health, and content of this podcast does not necessarily represent that of the NIH. Thanks, everyone, for tuning in, and happy trials.